Hello, everybody. Thank you so much for joining us tonight. We really appreciate it, and it's great to see that so many of you have managed to attend. I'm Marie McCary. I'm Chief Nurse here at the Care Inspectorate, and tonight we've got a really fantastic expert panel who've come along to support you in terms of increasing your knowledge and your learning about preventing and managing infection in childcare and education settings, and what this might mean for you in practice. So I'm just here to do the introductions and to keep everything going along to time, and I'm going to introduce you to all the members of the team that are here tonight. We've got a good number of people here with us in terms of audience, but we're expecting a few more. So I'll go slowly on the introductions and see if a few more people manage to join us. So without any further ado, I'll introduce you to our team. First of all, the most important person in my point of view is Jenny Ross, who's our improvement support advisor, and she's going to be doing all the behind scenes work to make sure that the presentation's working and that we're all hearing and seeing what's happening on the screen. So hello, Jenny, and could you move my slide along to the next one, please? I'm going to do some introductions and some housekeeping with you. So the webinar will run for approximately an hour and a half, and we'll record the webinar so that we can pass it on to you after the event. Excuse me, sorry. And also so that you can pass it on to people, colleagues in your workplace who might not have been able to manage along today. Your microphones and your cameras have been switched off, and that's a deliberate thing. And it's to help us with the broadband and the width and to make sure that we don't lose connections tonight. But if you could use the chat function to ask questions, there are 6 experts here with us tonight. My colleague Jackie described them as infection prevention and control royalty. So that's who we've got with us tonight. And they'll be able to answer your questions and answer at the end of the session. We've also got some polls that we're going to do as we go along, so that it's a wee bit interactive and so that we can hear your thoughts as we go along, and so that we can glean what it is you want to know and how we can better support you with future webinars. And we'll send you the slides that you're about to see in the recording that we're doing after the webinar. So as I mentioned, we're joined by an expert panel of health protection nurses and nurse specialists and leads who've got many years of experience in the field of health protection, and what that might mean for you in practical terms. Our guest speaker tonight is Fiona Browning, and Fiona is a health protection nurse specialist from NHS Grampian, and she'll also be taking part in the questions and answers later on. But we've also got Helen Corrigan, health protection nurse consultant from NHS Grampian, Rona Kirkham, health protection specialist nurse from NHS Grampian, and Chioma Nwagu, also a health protection nurse specialist from NHS Grampian. Chioma, please forgive me in terms of how I've pronounced your name. I'm sure you'll be able to correct me as we go along. And finally, Jacqueline Tolan, health protection specialist nurse from NHS Lanarkshire, and Joanne Miller, health protection specialist nurse from NHS Lanarkshire also. So first of all, I'm going to introduce you to Fiona and tell you a little bit about her and her role as a health protection nurse specialist. She's worked in the health protection team at NHS Grampian for 30 years and was an infection control nurse in Oxford before that. Initially, her job was a communicable disease control nurse, and that job and job title changed to public health infection control nurse before her current title of health protection nurse specialist, and that's kind of in line with how her role has developed and expanded over the years, because it's a vast subject. But her special areas of interest include vaccine preventable diseases, which in your world you'll know a lot about, and also in the area of school and nursery settings. She's an expert in supporting schools, nurseries and childminders to learn about and adopt fundamental IPC precautions to protect them and to protect people that you use your service and to reduce risk in terms of the spread of infection. Fiona's really keen to help adapt guidance so that it's setting specific, so that it makes sense in your particular setting. I hope that introduction makes sense to you. Could you move the slide on, please, Jenny? So the aims of the webinar today are to highlight the role of the health protection teams. And as I mentioned, we've got 6 experts here, so I'm sure they'll be able to do that justice and tell you about who they are and what they do and how they can help you. Highlight how to prevent and manage infection in childcare and education settings. Offer a refresher on standard infection prevention and control, precautions in practice, so you might know them as SIPs, and offer an opportunity to participate in questions and answers at the end of the session. Next slide, please, Jenny. And I'm going to pass you on to Fiona, and she's going to tell you the really interesting bit, and I'll catch up with you later in the webinar. Thank you. Fiona, over to you.
Helps if I take my mic off, doesn't it? Off mute. Happily saying, "Hey, Fiona."
I'm going to put my camera off, Fiona, just so that I'm not distracting people from your presentation.
Oh no,
but I'm here.
Oh, you've muted yourself, Marie.
Yeah. Oh, sorry. What I've just forgotten that I meant to tell everybody at the very beginning was we've tried to put a system in place if you are putting some questions in the chat box so that we can answer them as we go along. And there are 6 health protection specialists here. And so what we thought was we would use the little high 5 symbol to say that one of us, not me, one of the team are going to answer your question, and that we'll get to you with an answer, so that you know who that is and who's going to answer your specific question. So if you see a little high 5 after your question, it's to say that one of us is going to answer that. We chose the high 5 symbol because we thought some of you might use the thumbs up or some of the other emojis as we go along in the presentation. So sorry, Fiona, I'm taking up your time.
Not at all, please don't worry. It's absolutely fine. I'm just going to start battering through these slides, and I'm personally going to ignore all the questions at the side, because obviously my colleagues will deal with any questions as they arise. So yeah, let's just kick off. So really tonight we're going to be looking at how we manage and prevent infection within childcare settings, and obviously we're going to look at the chain of infection, how we prevent and control infection, SIPs that we've already mentioned, and we'll have a little bit of a session on infections and outbreak management. And I know there's been a few questions submitted already that I'll try to cover during that session, but obviously that part of the session, but obviously feel free to submit your questions as we go. That's great. Jenny, next slide, please. Thank you. Oh, the polls. Yeah, well, the questions are going to appear on the screen and in the chat. So I think they're already in the chat, aren't they? I'm just looking here to see. I was going to ignore the chat, but there I am. Jenny, are you putting these in the chat?
The first question should be appearing on the screens and in the chat just within a few seconds.
There we go. I'm just letting you do that. So if everybody has a second to...
I think it makes interesting reading, Fiona, because
it does. Because I'm very confident about the topic, but I find the guidance very difficult to manoeuvre through. So yeah, it's interesting. That is good.
So it's quite reassuring. Quite a lot of folk find they're okay, and others, find what they need. So yeah. Mm-hmm. So thank you for that.
Yeah, that's really interesting. Thank you. Okay, can we move on now then? Or thank you. Yeah, I just wanted to start off by saying that every single one of you, because I'm conscious that there's members on this chat from all over Scotland tonight, and it's just to let you all know that, if you didn't know already, that you all have your own health protection team in your board area, and you'll get the slides later, but these are the details on how you would get a hold of the health protection team in your area should you have any particular questions, and they would be able to help you with that. Next slide, Jenny. Thank you. Before we start thinking about infection, I think it's really important that we remember that all of us play host to an assortment of bacteria, viruses, fungi, parasites all the time. A whole range of microorganisms that cause us absolutely no harm, and that can actually be quite protective for us. Bacteria that would normally be found in our throat, for example, not causing us any problem when it's in our throat, but if it gets somewhere else within our body, then that can be a problem. And I'll move on to that with infection in the next slide, please, Jenny. So infection happens when these bacteria go from where they usually would be, so as I say, throat, the normal flora, the normal bacteria, microorganisms in your throat, and they get into your bloodstream, for example. So you'll have seen, you're working with kids, so I'm sure you'll have seen strep throats, and then you'll have seen that become a bit more systemic with other infections, scarlet fever, that kind of thing. All a range of the same kind of organism, but causing different problems. And when these organisms multiply and kind of move into a different area, that's when we start to see symptoms. And those symptoms can be a whole range of different things. They can be fever, pain, swelling, rashes, presence of pus, but there are other symptoms of infection that you might see as well. And obviously when we get an infection, we need to address that. Next slide, please. So colonization, so the presence of these microorganisms on and in your body, doesn't require intervention unless it's to minimise the spread to other people. So you'll find that people with meningococcal infection, for example, we call it the bacteria that causes meningococcal infection, can sit in the back of the nose and throat of a fair amount of people, causes no harm whatsoever. It's part of our normal flora, and we wouldn't normally do anything about that. However, if we would intervene with that if there was somebody in that social circle that had meningococcal disease, and then what we would do is give prophylactic antibiotics. So antibiotics that we would give to people in order to prevent an infection occurring. So the organisms are there, but they haven't actually set up an infection, an infective response. So we would try to prevent that happening. But on the whole, a presence of organisms in your throat, up your nose, on your skin, aren't going to cause any problems, so we wouldn't do anything about it. However, if you have an infection, so there is the presence of symptoms, then we would normally treat with antimicrobials. So whether that's a viral antivirals or antibacterials, we do antibiotics, then that would be the thing. That would happen. So the next slide, please. So how do we get to this point where we've got an infection? So we call it the chain of infection. I'm sure those of you that have seen certainly the old book that we had, the Managing Infection in Childcare Settings, had something like this, and I think it's in the new one as well. But we start at the top here with, oh, I can't do that, it's not my slide. Infectious agent at the top. So this is where we've got the presence of an organism, and it's got the potential to make people unwell. It doesn't always mean that it will make people unwell. So maybe influenza or norovirus or something like that. So we've got an infectious agent. So from the infectious agent, we need a reservoir. So that's where this germ would live and grow and proliferate. And for example, that could be in somebody's respiratory tract, so pertussis, for example, or flu, or in their gut, like norovirus, or other organisms as well. So that's where it's living and growing and proliferating. We're getting more and more of these organisms. We then need a way for it to come out of the reservoir, so a portal of exit, so where the germ finds its way out of that individual and sets up this ability to spread to other people. And that would be, for example, the norovirus, it'll come out, sounds gross, comes out of the person by having that person having sickness and diarrhea. So that's the portal of exit. And obviously those organisms then are spread in the environment, which creates this mode of transmission at the bottom. And that it would be on the environment, on hands, on items that have been contaminated because somebody's been sick or had diarrhea. And then that would then needs a portal of entry to get to the next person. This is the most complicated bit of tonight, I promise you. And it needs to find its way in, and that could be, for example, through the mouth, or on the mouth, so contaminated hands going to the mouth, or somebody's been coughing and sneezing and they've got respiratory particles on their fingers, and then they rub their eyes. That can kind of introduce that into another person as well, or in body fluids and things like that. So that would be the way that it would get into another person. But even then, that person that the organism is finding the portal of entry to needs to be susceptible. So, you know, you may well eat some food that's contaminated with salmonella organisms, but that doesn't mean you're going to necessarily get salmonella. So there's a whole range of different things that would need to take in place, including infectious dose and stuff. And I'll come on to that in just a tick. But a susceptible host would normally be, in this situation, child or young person, but actually it could be you guys as well. You're at risk of infection because you're unable to fight it off. You know, maybe you've got an underlying medical condition, or you take medication that weakens your immune system, or you're very young or you're very old when your immune system's perhaps not as efficient as it could be. So effectively, that's the chain of infection. And what we need to do as practitioners is try to break that chain of infection. At any place in there, if we break that chain of infection, it stops the next stage happening and minimises the risk of spread to others. Okay, next slide, please. So the host susceptibility, as I was starting to touch on, extremes of age, so very young, very old. Very young, their immune system's not up to speed yet, I reckon around kind of age 4 or 5 before you've really got an efficient immune system. Excuse me. And the very old, I always think of the very old as their immune system being like the first car that I ever had. Every time I drove it through a puddle, it broke down. And it's that kind of, it's just not as efficient as it could have been. Men and women are statistically more likely to get infections than men, but I often think, is that because women are more likely to report it and do something about it? That could potentially be the issue. But certainly that's what we see. Your physical and your psychological well-being, we're just coming out of winter now, thankfully, but how many people have been unwell over the winter? You never see the light of day because you're always at work. You feel a bit run down. Those of you that get cold sores probably get cold sores because you're feeling run down. It's just that whole kind of downward spiral because you're just not feeling at your peachy best. As I said earlier as well, chronic disease or other infections or treatment, so medical intervention in order to address that can sometimes weaken the immune system as well and making you a bit more susceptible. Basic hygiene can be a thing as well. Well, is a thing. So, I mean, like people with poor hand hygiene who are maybe eating food then that's contaminated by dirty hands potentially could be a risk of acquiring infection as well. And also importantly, immune status. Clearly, if people are not vaccinated against vaccine preventable diseases and vaccine preventable diseases are circulating, they're more likely to acquire that infection. We've just gone through a whole period at the end of 2023 and mostly through 2024, where we were dealing with a lot of whooping cough circulating in the community. We're just going through the winter, a lot of flu circulating. So lots and lots of different things that we need to take into consideration there. Jenny, next slide, please. So these routes of transmission are direct or indirect. So direct contact is pretty much what it says on the tin. Person-to-person contact. So examples of that would be scabies. So you would really have to have skin-to-skin contact to pass scabies from one individual to another. But other things like norovirus, E. coli, so whilst they would have other ways of other routes of transmission that could happen, they would still be direct as well. Indirect contact would be on objects, food, water, that kind of thing. So we've got norovirus here as well, but obviously E. coli could be one of those as well. Cryptosporidium, salmonella, so various other things that food or water could be contaminated and pass the infection on to others. Next slide, please. So the respiratory route is one of these routes that we're looking at, and this is obviously respiratory secretions, so coughs and sneezes spread diseases. Yes, they do. Interestingly, it's if somebody coughs, if you cough, you can cough up to 50 miles an hour. That expelling of air when you cough can be up to 50 miles an hour, and around something like 3,000 droplets can come from your mouth as well. Sneezes actually win the gambit on that. We're looking at 100 miles an hour that somebody will sneeze at, and 100,000 droplets. And you can see from this slide, droplets are the heavier particles of respiratory secretions, and they tend to drop at around less than 2 meters, really. But that doesn't mean that we're out of the woods, because the lighter particles, and that would obviously include virus particles as well, would be transmitting through the air, and with the air circulating in a room, for example, you'll find that organisms, particles, respiratory droplets will be able to spread further than you would maybe originally think. And this is one of the reasons why when we're speaking to people, I know it's not respiratory here, but when we're speaking to people about cleaning spillages of vomit, we want them to clean a 3-meter area around, because you've got these other smaller particles that are more airborne and can land on horizontal surfaces a lot further away than you would think. So as I said, we've already said about coughing and sneezing, but also singing, kissing, children mouthing toys. These are all ways that respiratory organisms can transmit. Excuse me. And examples of infections that would be spread that way would be measles, mumps, flu, COVID. We should all remember a lot of that. And as I said earlier, whooping cough as well. Okay, so the next slide, please. The fecal-oral route is very descriptive, and it is fecal contamination of something that then is put into someone's mouth. And that would usually be on poorly washed hands, but it could also be on items that have been handled by contaminated hands, and then that item's been put into the mouth. And also, there's also direct contact with feces, so picnicking, for example, and coming into contact with rabbit droppings, that kind of thing, would also be an opportunity for direct contact to happen there. And what we're looking at here, organisms that give us a bit of concern, a big bit of concern, are E. coli, 0157 or other S-tex, we call them salmonellas, Cryptosporidium, so a whole range of different organisms. Here is only a snapshot of examples. There's many, many more. Next slide, please. The sexual route is another route of transmission that we look at, and usually that would be through unprotected sexual contact or intercourse, and a whole range of other organisms there as well, that we are interested in, and looking at how these are transmitted and looking at how we can prevent the spread of those. I'm doubting that many of these will impact on you and your work place, so I'm not going to kind of dwell on any of those at the moment. Next slide, please. The vertical route is from mother to baby, and that is either whilst mum's still pregnant with the baby or during or shortly after birth. And again, a whole range of organisms. These are just a few examples. The Streptococcus group, there's a typo in here, that's meant to be group B Streptococcus, that we would be looking at. And generally, group B Streptococcus is one of these organisms that can sit quite happily in in the birth canal of women, some women. Doesn't cause them any problem. It's one of the organisms that they can be colonised with. But it can have a real harmful impact on the baby. So when it's known that women carry this, there's generally, they would be started on an antibiotic when they're at the point of delivery, and the baby would be placed on antibiotics, because again, you're looking how you would break that chain of infection. Listeria is one as well that's quite a significant one for pregnant women. Most people with healthy immune systems can deal with listeria quite happily. You know, they'll swallow listeria organisms, and it doesn't affect them in any way at all. And actually, even the pregnant woman swallowing listeria organisms probably going to be okay, but the baby may not be. And so that's why, again, looking to break the chain of infection, pregnant women are told not to eat things like pâtés and unpasteurized products, because these are products that we know can contain listeria organisms in them. And things like hepatitis B, obviously it's a blood-borne virus and can transmit from mother to child during the pregnancy and or shortly after birth. Next slide, please. Vector-borne route insects, the creepy crawly route, I hate this. Indirectly through contamination of food or objects that are going to be placed into the mouth. So if you think of flies, will fly about the place, they'll sit on animal droppings, and then they'll go and sit on your nice sandwich, and then you've not noticed and you eat the sandwich. So these organisms that were on their feet are now on the sandwich, and are now in your mouth. So it's about making sure you keep food, not like it is here on this slide with the watermelon, keep it away from being able to be contaminated by insects. Direct contact obviously would be through bites. In this country, we get a bit of Lyme disease, a tick-borne disease, and that's generally, we generally find that in places, people who go walking in grassy lands, so, and occupationally, so gamekeepers, for example, might be prone to that. And the way to do that, to break that chain of infection, is to check your skin. If you've been out in these environments, check your skin, and if you've got any ticks, get them off quickly, and the chances are you'll avoid Lyme disease as well. Next slide, please. The blood-borne route, I mean, I'm sure everybody's kind of aware of as well, and that would be the transfer of blood or body fluids from an infected individual to someone else. And that obviously can be done through sharing contaminated injecting equipment, puncture with contaminated sharp objects, breaks in the skin through bites or cuts from an infected mother to her child, and during unprotected sexual intercourse are generally the main routes of transfer of blood-borne viruses. Next slide, please. So with blood-borne viruses, it's really important that we're aware of the organisms that of the organisms. I didn't think that sounded right in my head. Of the fluids that are riskier than others, and so obviously we've kind of just highlighted them here. Obviously, blood. It's a blood-borne virus. You don't get points for knowing that blood would have these organisms in them. HIV, Hep B, or Hep C have these viruses in them. But you'll see here, like, so HIV and hepatitis B, breast milk can be transmitted in that way, semen, vaginal fluid, hepatitis C, not for breast milk, but semen and vaginal fluid, although less commonly. But again, we'd always be looking at how we would break that chain of infection. So for example, if a woman's got hepatitis B and the baby is vaccinated early and given immunoglobulin early, the woman will still be able to carry on and feed her baby breast milk. So there are ways around this, and obviously with HIV it would depend on viral load and things, but the health professionals, the clinicians, would be able to advise on that as well. Okie doke. Next one, please. So really what we're trying to do is to prevent the spread of infection. You're never going to stop infection. Infection is going to happen. We're humans, that's life, it's going to happen. So what we need to do is to try to prevent it getting a hold. So we're looking to do that through education, applying appropriate control measures, knowing when to ask people to isolate or even just to stay off work or school or nursery or not come to the childminder. Use of antibiotics, but antimicrobials of any kind of description, and immunization is probably the main one. Next slide, please. So immunisation is the mainstay of the UK infection control programme. There's no doubt about it. We have a massive programme of immunisation in the UK, something, I used to know this off the top of my head, but something in the region of 11 or 12 different antigens that we're protecting people against routinely, and then others on top of that. So, and if you're travelling abroad, there's access to other vaccines as well to protect you if you're in an area, in a different country where different infections, vaccine preventable infections, are prevalent. Next slide, please. What we're trying to do with immunisation is not to stop all infection, because there's no way we'd be able to vaccinate 100% of the population, even if everybody was willing. There are reasons that some people can't be vaccinated, people with underlying immune issues that can't have live vaccines, for example. So there are different reasons that we couldn't vaccinate everybody. But that's okay. We don't need to vaccinate everybody. What we need to do is achieve what we call herd immunity. And herd immunity is when we've got the number of susceptible individuals and the number of infected individuals is less than the number of immune individuals. And that varies differently for different organisms, but usually we'd be looking at having around a 95% of the population be vaccinated against vaccine preventable diseases in order to protect everybody. That, because you can see from the first part of this, the first slide, I can't do that because the no herd immunity. So you can see the little red people. And the blue people are susceptible. The red ones are the infected ones. You can see how easily an infection would spread through that community. The diagram on the right, you can see you've got your red infected people and you've got a couple of blue susceptibles around the outside. But for the most part, that community is immune. So a disease is not going to get a hold in that community and we won't have massive outbreaks. Next slide, please. I'm really gutted because this usually is animated, this slide, and it usually works really well, but it's really just it just shows how things spread. So we might as well skip over it because it's not animated, so it's not going to show you what it does. We used MMR as an example of what we're looking to achieve herd immunity, and for measles we're looking at 92 to 95% uptake. And for mumps, 90 to 92, rubella a bit less at 85 to 87. But the World Health Organization recommends that we're aiming to achieve 95% uptake. And MMR, the schedule is a 2-dose schedule given at 12 to 13 months and then again at 3 to 4 months. The first dose is very effective. The second dose mops up all those that were missed on the first dose. Next slide, please. So this was those of you that have been childminding for a while will remember, maybe that long, but will remember this document, the Infection Prevention and Control in Childcare Settings, which was the one that we used to use. This has been replaced by the Health Protection in Children's and Young People's Settings, including schools, and that was the guidance that was circulated to everyone last year. Could you just slip on the next slide, please, Jenny? Yeah, thank you. And it was really reassuring to see that a lot of you are actually finding access to this not too bad. So that's really good. That is really good. But it would be useful to have some feedback and comments that would make it more useful to you. That would be kind of really helpful. I'll leave that with Jackie and Jenny to see if we can get some feedback from you on that. Next slide, please. It really is, I guess the thrust of this document is that really what we're looking to do is to remind people that we need to be risk assessing all the time. We need to be thinking about every day, everything that we're doing every day, and what that level of risk is and how can we address it. And this is the hierarchy of controls, they call it. At the top, we've got the most effective kind of control measures that you can put in place, down to the least effective, and that's even the least effective we don't want you to stop using, but it's there, okay. So elimination is obviously the best thing. If something is not a hazard at all, then that's even better than having to prevent it. So if we're going to physically remove a hazard, I mean, obviously something like that would be like you wouldn't have sharp knives hanging about, so you would remove them, so you've removed that risk. Obviously that's not an infection one. Substitution would be where we would replace something. So tiny toys, you would remove them, have bigger ones, so you've not got a choke hazard. It's that kind of example that we're looking at. But again, these are things that, so substitution from an infection prevention control point of view, well, if you've got an enteric illness, so you've got people who have got diarrhea, then you would never use alcohol hand rubs. You should always use liquid soap and running water. So it's about replacing things as well. Not that I would want you using alcohol hand rubs all the time anyway. Engineering controls, so you would remove, for example, you'd remove children from a room. If a child has been sick, remove all the other children from the room until you're able to get that cleaned up. And that would be a way of isolating people from the hazard that's there. The administrative controls, something as basic as not going to work, not allowing children into the setting if they're not well. It doesn't matter what's wrong with them. If they're not well, they shouldn't be there. And it's the same with the staff as well. And that would be changing the way you work, so in order that you're preventing an infection taking a hold, because you're not going in if you're not well. Especially, we've had a bit of a hit on that ourselves with kind of flu-like illnesses and things. And PPE use when you're changing nappies, when you're likely to be in contact with blood and or body fluids, and obviously these are the you should be using those. If you're assisting with toileting or nappy changing, that kind of thing, use your PPE at that point, or when you're cleaning up the vomit spill. Next slide, please. So, standard infection control precautions. We talk about two things here. We talk about basic principles. For me, basic principles is don't go in if you're not well. So that's the children or the staff. Don't go in if you're not well. The second one is about maintaining a clean environment, good and regular hand hygiene, hand washing, and good cough and sneeze etiquette. And if you can adhere to those four basic principles, you'll go quite a long way to preventing anything happening within your settings without getting an outbreak in your settings. But more than that, we've got standard infection control precautions. Next slide, please. And obviously, standard infection control precautions are simple measures that should be applied to everybody all the time. And then that way, it doesn't matter what you think you might know, what infections people have, because you're working in a safe way and you're protecting the other children in your care. Next slide, please. The first one is really around hand washing, and that is the single most important thing that everyone can do to prevent the spread of infection. And it's something that we should be encouraging children to do really early on. I mean, here's a good example of a child washing their hands with support under running water. You know, we've heard all sorts of stories over the years of how very young children are able to get their hands washed. So babies who are not able yet to stand at a sink, how do they get their hands washed? Whatever you do, it needs to be under running water using liquid soap. It shouldn't be in a basin or a sink with a plug in and their hands getting dipped in the water. There must be a way that you can adapt to get their hands washed under running water. Next slide, please. It's well recognised that we miss lots of areas on our hands when we wash our hands. I'd like to think I don't, but I'm sure we do. So we know that the thumb, for example, often gets missed. The fingertips often get missed. The web spaces often gets missed. And if you look, the fingertips and the thumb, if they're not getting washed properly, and they're the things that are bringing food into the mouth, they're not just bringing food into the mouth, they're bringing whatever's contaminating the thumb and the fingertips to the mouth as well. So it is really important that we start really encouraging children to wash their hands well from a young age, and get them into the habit of knowing that they need to wash their hands without prompting, because when you get people like us from health protection teams wanting to exclude children from childcare settings, it's usually based on how well they can wash their hands without being prompted. So maybe an opportunity to push that in there. The next slide, please, Jenny. So the things to consider. So liquid soap, does it need to be antibacterial? Well, no, it doesn't need to be antibacterial. If people are using a soap that they like, that makes their skin feel nice, doesn't nip their hands, they're more likely to use it and use it well. If they're using an antibacterial soap that dries their hands out, they're less likely to use it well. So that's certainly not an issue there to have to use antibacterials. Hands need to be washed thoroughly, making sure that they get all areas of the hand surface and web spaces and fingertips and thumb thoroughly washed. Paper towels to dry. Obviously, childminders, I know that a lot of you won't have paper towel dispensers in your bathrooms. Why would you? But there are other things that you can do to accommodate that. So one of the things that we've recommended to some of the childminders in our area is even just having like just cheap face flannels and keeping a stack of them, so that when children dry their hands, that face flannel can then be put into the laundry directly. So it's only getting used one time, but then it's getting laundered. Hands need to be dried thoroughly. Obviously, if hands are not dried thoroughly, then hands become chapped and sore. If hands become chapped and sore, two things happen. You've got broken skin, which harbours organisms really easily. And also you've got sore hands that are not going to be washed well, because nobody wants to wash their hands when their hands are really sore. We've got alcohol hand gels and rubs here, and generally this is here when I'm doing a face-to-face and we get a bit of chat going, but obviously it's a bit difficult to get a bit of chat going with 450 of you. So, but we wouldn't be recommending alcohol hand gels and rubs in a childcare setting. There's really no need to do that as long as hands are being washed thoroughly and regularly and at appropriate times. We've put wipes here, and the reason wipes is here is like if you were out and about and you're in an environment where there's nowhere to wash hands. So if you've gone out to the park or something and the kids have fallen over and dirtied their hands, you're much better to use a wipe and then wash their hands when they get back, rather than an alcohol hand rub, because an alcohol hand rub is not going to be effective on hands that are not already socially clean. For those of you that are working in these environments, it's really important that you don't have long or acrylic nails, because long nails, obviously, you can kind of organisms can sit quite happily in the nail beds, and it's really difficult to wash that out if your nails are long. False nails, again, attract and harbour organisms, really difficult to get them washed, and varnish as well. Again, harbour organisms and make it difficult to actually wash your hands properly. When we do these sessions in a face-to-face, we have, you might be able to access these from your local health boards as well. Oh my goodness, what do we call it? The glitter bug, a glitter bug. And so you've probably used it at some point when you've done sessions before, and it's like an ultraviolet light box that you put your hands into, and there's a cream that you put on. And quite often, always, what we find when people have got long and fake nails and nail varnish on, we find that in the nail beds, in the cuticles, that's where a lot of this accumulates, and it's really difficult to wash that out. So I mean, it's really easy to evidence by using a light box like that. You should make sure that you're not wearing wristwatches, bracelets, rings with stones in them, or rings with ornate designs, because again, that's where dirt and organisms will sit quite happily, and it'll be really difficult to wash that out, and then it's easy for that then to transfer on to others. And really, you shouldn't have long sleeves when you're washing. If you're, I mean, obviously in a childminder setting, you may well have long sleeves, but you need to make sure that these are rolled up properly when you're providing care, so that you can wash your hands properly, wash your wrists properly, and make sure that you're getting a good hand wash in order to prevent and minimise the risk of spread to the next individual that you're working with. Excuse me, sorry. Next slide, please. So with the children, you need to think about when do they wash their hands. I mean, obviously we'd be looking at hands being washed before food handling, after they've come in from outside, obviously after they've been to the toilet, after messy play, and is that hand washing supervised? So I know that, you know, we're really keen to promote independence in children, but you need to have a thought to how well a young child's going to wash their hands, and it would really be advisable to supervise that hand washing. And where would the hands be washed? Are the sinks at a right level, or have you got a step for the children to stand up to wash their hands? And if they're too small to stand, if they're little babies, for example, how are you washing their hands? And as I said before, that needs to be under running water. With liquid soap and drying with paper towels, or with the flannels, things that you can then put for laundering. Excuse me, sorry, my throat's going a wee bit. Next one. So when would you wash your hands? You need to think about two things. Again, we were saying earlier, it's about risk assessment. You need to think about, what have you just done? What are you going to do? These are the two things that you need to think about for this. So obviously, visiting the toilet, hands are visibly soiled, really important one. Before preparing, handling, or eating food. Again, most people are pretty good at washing their hands before they prepare or handle food, but they're less good at washing their hands before they eat food, especially if they're out and about. I don't know how many of you have maybe gone and filled your car with petrol, handled that petrol pump that however many thousand people before it have handled, before you nipped in to pay for your petrol and bought a bag of crisps on the way out, opened the bag of crisps and jammed it between your knees. Most people haven't washed their hands before they've gone and eaten that bag of crisps. So it's just about thinking about what you're doing, what you're away to do. You should be washing your hands before and after you've worn protective gloves. Sometimes that's not immediately before you've put on your gloves. Sometimes it's that you've finished a task, you've washed your hands when you've finished the task. A little bit later, you're just away to do another one, so you put your gloves on. After you've handled contaminated articles, I mean, I'm sure you work with children. How many times have they handed you a snotty hanky or something like that before you've had a chance to even just give them the bin to put it in or whatever? So you're going to get caught short with handling contaminated articles without question. Next slide, please. Really difficult, and until we're able to have an alarm everywhere, we need to try to just encourage this compliance to make sure that people are washing their hands every time they go to the toilet. Even if we could get that going, that would be a good start. But yeah, let's have a bit more compliance with that. Next slide, please. There's lots of places that you can get additional resources. So if you wanted to do a bit of work with the children, the National Infection Prevention and Control manual has a hand washing children's pack. There's a children's section in there. I mean, that's where you'll find some of you have maybe seen the whole handy Andy thing before, and you'll find that in there. But Food Standards Scotland also, they even have like some little lesson plans that you can do if you wanted to do a wee session with the kids on washing their hands. And then there's the eBug, oh my God, my words have gone. It's the UCS, it's the English Health, the UK Health and Security Agency. They have a program called eBug, that you can get information from as well, that can help you to do some work with your kids and your adults. Next slide, please. The next part of standard infection control precautions that we're just going to have a quick look at is protective clothing, so personal protective equipment. Next slide, please. So really, again, everything's about assessment. We assess all the time. My colleague who's in here tonight is often telling folk that you assess when you're going to cross the road or not as a risk assessment. And that's what we should be doing all the time. We should be thinking about what we're doing. So are you going to have contact with blood and or body fluids? If the answer to that question is no, then you don't need protective clothing on regardless. If your hands are in contact with blood and or body fluids, then you need single-use disposable gloves. And if there's a risk of splashing, you'll need a disposable plastic apron as well. And that would be for your day-to-day things. I mean, obviously in hospital settings or in care home settings where we've got outbreaks of flu or whatever going on, then mask use is going to be introduced there as well. But you wouldn't need that in a childcare setting. Next slide, please. Remember that gloves need to be well-fitting. They're for single use only and for specific tasks. So it is not helpful to put on a pair of gloves in the morning and keep them on all day, because all you're doing then is smearing whatever you've got on the gloves onto whatever surfaces those gloves come in contact with. So they should be removed after each individual task that you've worn them from. You shouldn't wash gloves. Washing gloves disturbs the integrity of the glove and actually makes them a bit more porous, which means then that they're not protecting you. So you should not be washing gloves. And also, they're not a substitute for hand washing. So you should be washing your hands as soon as you remove your gloves. And when you're removing gloves, try to have a care at how you're removing your gloves so that you're not contacting the surfaces of the gloves that have been in contact with the nappy or whatever. Try to take them off from the inside, if you know what I mean, and then dispose of them that way. You remove them immediately after your contact with blood and or body fluids, and you may find, rarely, but you may find that people are allergic to certain types of gloves, in which case there are lots of different manufacturers and you can get some advice on what gloves are best. I think there's some glove guidance as well available through the Care Inspectorate. Maybe landing you in that, but I think there is. Next slide, please. Aprons again are for single use. You shouldn't be wearing an apron the whole day, the same apron all day. It needs to be taken off after each task and disposed of, and then hands washed after removing your apron. And again, when you're removing your apron, don't just grab the front of it and yank it off. Actually untie it, take it down so that you're handling it from the inside, not actually from the outside, so that you're not contaminating your hands. I don't know why I felt the need to do that, but you're not contaminating your hands. Not so much in childminder settings, but perhaps in nursery settings, sometimes we see that people are using different coloured aprons for different tasks. So, for example, they might have a yellow apron for their food area. And again, that's really good. It means then that nobody's going to drag you in to do something else because they know that you're food handling at that point in time. So it's quite a good thing to do that in order that you don't get distracted from the task that you're doing and you're able to complete it and then move on to the next thing. Next slide, please. So how do you take it off? I mean, obviously we've put mask in here, but you're not going to use a mask. So if you're putting on, your apron goes on first and then your gloves go on. When you're taking off, your gloves would come off first and then your apron would come off. And as I say, taking care not to handle the front of your apron. Okay, next slide, please. I mentioned earlier about cough and sneeze etiquette and how that, for me, that's part of basic principles. And really, this is about, you'll have come across this, I'm sure, covering the nose with nose and mouth with a disposable tissue when coughing or sneezing. I mean, there was a lot of chat around this during the pandemic as well. And then that's about catching whatever it is into your tissue. Any tissues should then be put into the bin, and then hands should be washed using liquid soap and running water. If you don't have a tissue, and again, it's good to encourage the children, remember to encourage them to then cough in or sneeze into the crook of their elbow if they haven't got a tissue to hand. And again, washing their hands is really important here. Okay, next slide. I feel like I'm battering through these now. It's because nobody is speaking. Again, there's lots of resources available, posters that you can have, looking at the Catch It, Bin It, Kill It programme for the NHS. They're just everywhere. You just have to Google them and you'll find them everywhere. So yeah, just to give you an example of those. Next one, please. Again, next thing then with standard infection control precautions is about our linen and what we're using on site. Now, I think if most of your childminders, you're probably going to have a washing machine on site, and it may well be that you do some laundry for the parents. You know, like if a child gets their clothes dirty, you might just throw it in the washing machine that day, and that's probably okay. Where we wouldn't be recommending that is in a nursery setting where you've got loads and loads and loads of kids, and anything then needs to be bagged and put away. We'll come on to that in a minute. So you need to think about what laundry you're processing on site. And again, as I say, that can vary very much between whether it's a childminder or whether it's a nursery setting. And where is that laundry being done? Is it being done in a separate room, in a bathroom, in a changing area? Or God forbid, is it being, well, not as much in the childminders, God forbid, but is it being done in the kitchen? So, I mean, there are things that you need to consider, and depending on that, what you're going to do with it. You need to think about what you're doing with wet or soiled clothes. So if a child vomits on their clothes or they have an accident in their clothes, what are you doing with that? Can you move on to the next slide a minute, because I can't remember. So what we would generally say is that if you've got soiled clothing, we would want you to use your protective clothing. So have your gloves and apron on, scrape whatever's on the clothing into the toilet using tissues or whatever, and then bag in a waterproof bag the clothing to be collected by the parents and taken away by the parents. You should never hand sluice things, because if you do, it's a great idea to think, oh, I'll just run it under the tap and I'll get the worst of it off. But actually what you do is you then end up with the water from the tap hitting whatever bit of clothing it is, and then that creates a splash, which is aerosolizing right in front of your face. So if this is an organism, if it is that this person's been sick or whatever because they've got a bit of a tummy bug, then you've just aerosolized all that, and now you're chatting away to somebody and swallowing it as you're speaking. So you should never be hand sluicing things. As I say, scrape into the toilet, placed in a sealed bag and sent home with the parents. Okay, next one. If you are doing laundry on site, don't overfill your washing machine, because really what you're trying to achieve is the free movement of the water and the detergent through whatever it is, whatever laundry it is you're processing. If your washing machine's jam-packed tight, it's not going to actually clean the laundry as well as you would hope. You should always use the hottest wash possible for the fabric, especially when you're processing other people's laundry, and keep soiled and clean laundry separate, and make sure your washing machine's well maintained. Next slide, please. Again, we talked about this earlier. It's about making sure that your environment is kept clean. So try to make sure it's not too cluttered. Keep it visibly clean. Keep the outside outside. A lot of you the kids will have indoor shoes or indoor slippers that they wear when they come in, and get them into the habit of taking their outdoor shoes off at the door and putting their slippers on, and then washing their hands, because if they're taking off outdoor shoes using their hands, whatever's on their shoes is now on their hands, and they need to wash their hands. Have a cleaning schedule for toys and equipment. Rotate your toys and equipment to make sure, to make sure that you've got that opportunity to get them clean. And then obviously crockery and cutlery, most people have access to dishwashers, but if you don't, just make sure that they're washed really well at the hottest temperature you can manage, using a detergent. Okay, next one. So cleaning, we're just going to have a quick look at cleaning, disinfection and sterilisation. Okay, so cleaning is a process that physically removes organic matter. So blood, feces, urine, vomit, anything like that. And a basic detergent suitable for that surface would be enough usually to do that, unless we think we've got a bit of a tummy bug going on. You should always clean before you disinfect, without question. There's no point in slapping a disinfectant on top of feces, for example, because it's not going to do anything. You need to use a bit of elbow grease and detergent to get rid of that, and then disinfect the area. You shouldn't use boiling hot water or cold water. It's very tempting to just see something's really dirty and think, well, I'll just boil the kettle and pour that on top of that. But actually what you'll do is you'll almost like create a biofilm almost, because you'll melt whatever the organic material is, and then it'll quickly cool, and you're just not going to create much in the way of a cleaning process. Much better to use general purpose detergent and a bit of elbow grease and a hand hot temperature. Excuse me. Next slide, please. Disinfection is a process that reduces the number of microorganisms to a safe level, so they won't be harmful to the children. So I mean, we often think about Milton sterilising units. Well, they're not sterilising. What they're doing is disinfecting. They're reducing that number of organisms to a level where they're safe. So the baby's bottles are safe to then be used again, kind of thing. Different ways to disinfect. Heat disinfection. So your washing machines, dishwashers. Dishwashers are great for cleaning Lego, for example. Put them in a bag in the dishwasher, in a porous bag in the dishwasher, and get them cleaned that way. And chemical disinfection. So bleach, it's a decent one, but obviously the Milton units, that's a disinfection process right there. Next one, please. Disinfectants need to be used at the concentrations they're recommended, because they've actually been tested, and that's their most effective level. So if it says 10 mils of X disinfectant to 100 mils of water, that's what it means. It doesn't mean 10 mils and one for the pot. You need to get that kind of concentration right to get the proper effect. And as I said before, you need to clean before you disinfect. You should never mix your cleaning agents. I once went to visit a place that had every imaginable cleaner, detergent, disinfectant, degreaser sitting under, and they were just throwing a bit of everything in. So just be really clear about this is my detergent and this is my disinfectant, and when you're going to use them. You need to consider the shelf life, so check that they're not out of date. And also, when you're using a disinfectant, usually there's a contact time, so it's not a case of just spraying a disinfectant on something and giving it a quick wipe and hoping that's the best of it. There's usually a contact time that you would need in order to make that its most effective. And it should have that on the COSH data that you should have as well. You should also comply with your COSH data regulations. I'm sure that you have COSH regulations. I'm sure you all have for all the products that you use. You know how to use it, when to use it, and you would have a copy of that in your files. You should never be filling your own spray, drinks or food bottles, but I'm speaking to childminders and nurseries here. I would think it would be very unusual for any of you to do that, but you'd be surprised what we come across in other areas of our work. So never fill them. Next slide, please. The sterilisation, so that's the complete removal and destruction of all organisms. And unless you're doing a wee bit of cardiac surgery on your dining room tables, I doubt that you're really going to need to do that. You really just need things to be cleaned and disinfected. And really this is required for items that include contact with broken skin or into the sterile body area. So again, keeping things clean is what you're looking to do. Next, please. So here you'll see we've got a contact time here. So we've used this as an example. So if you've got a blood fluid spill and it's on a body fluid spill, sorry, on a hard surface. If it's a blood spill, so a kid's had a nosebleed, or goodness, you've had a nosebleed, you need to cover the area with paper towels. And this is the one time you would put a disinfectant on first. So you would put on 10,000 parts per million of available chlorine. So that's effectively your think it's your 2% milk. You would check to see what it says on the bottle. And generally that would be, yeah, you would put that on, leave it for 3 minutes, and then clean the area up. If there's no visible blood, you would soak up the spill with paper towels and discard those, and then use your available chlorine after you've cleaned the area a wee bit. You clean it with detergent. You then discard and clean the area again with multi-purpose detergent. Do not put chlorine releasing, so don't put bleach or Milton onto urine, because that'll definitely create this kind of gaseous and make you feel a bit unwell. So it shouldn't be on urine, vomit, or feces spillages. Okay. Okay. Next slide, please. So if you've got a spill of body fluids with or without blood on soft furnishings, you're clearly not going to put bleach on your soft furnishings or chlorine on your soft furnishings. So you'd want to isolate the area. You should be putting on your protective clothing for the other spill management as well. Put on your protective clothing, absorb the area with, oh my goodness, absorb the spill with disposable materials such as paper towels or a bit of kitchen roll, even just an old bit of rag that you can get rid of, whatever, it doesn't really matter. And then we need you to clean the area with warm water and detergent. You could use a steam cleaner, for example, if it was on your carpet or something like that, and just keep the area isolated from the other children or from anybody else until it's dry. And then for both types of managing these spills, you would want to double bag all your waste, including the protective clothing that you've used, and then go and wash your hands. And that would be enough to manage that. Next slide, please. When you're buying toys, have a think about how you're going to clean those toys. If you've got a lot of kids coming through your service, then you want the toys to be clean. So if you've got toys that are really difficult to clean, that becomes a bit of a problem. So have a think about that. If you're not sure, you can contact manufacturers. They should be able to tell you how to clean their toys as well. The examples, obviously, we've got here, things like Lego and stuff, it's fabulous. You can shove them in a dishwasher, absolutely amazing. But again, think about how often toys should be cleaned. So who's using the toys? Are the children that mouth the toys? Young children are mouthing the toys. Where is it being used? Is it an outdoor thing or an indoor thing? And what is it? Sand, water play, that kind of thing. So think about what it is that you're using. And how you'd clean it and when you would change it. How often would you change the sand, for example? What are you doing with, if it's water play, what are you doing with the basin that you've got the water in? How are you cleaning that? And generally, you would need to clean that at the end of the session. Okay, next slide. As I said, manufacturers should have instructions about how to wash their toys. And again, I'd mentioned dishwashers, but also washing machines. Some soft toys can just be popped in the washing machine, or hand wash with a neutral detergent and air dry. I know there's quite a lot of wooden toys, for example, and again, that would just be a hand wipe, really wiping a toy down with a neutral detergent and letting that air dry. And think about rotating your toys so that you've got that opportunity to clean things, leave them lying, and then you can reintroduce them. I keep going to move my slides forward and then remember that I can't. Thank you. So next part of this is about preventing occupational exposure. So really that would be about how, what you would do in order to prevent you becoming infected in the workplace with anything. So next slide, please. So in terms of sharps injuries in the workplace, you need to encourage free bleeding and don't suck the wound. And that could be, it doesn't necessarily need to be like an injection, although there may be some children that you've got in your services that are diabetic. But if you sustain a needle stick injury, encourage free bleeding and don't suck the wound. Apply, once you've washed it with soap and water, apply waterproof dressing, and then record the accident. You should have a process for recording accidents in your workplace. Especially if there's a chance that wet blood has been introduced into blood kind of thing, into your under your skin, then it's important that you speak to A&E or your GP about that as well. Okay. And obviously that would be the same for the children. Next slide, please. Bites. Quite often in childcare settings, it's bites that we get calls about. And obviously here the risk is not to the person who's been bitten so much as to the person who's done the biting. Because obviously if they get blood into their mouth, then that could be an issue. But the risk is generally thought to be pretty low. Next slide, please. So the bitten person, if you've been bitten but the skin isn't broken, there really isn't any risk of blood-borne transmission, so just wash the area really thoroughly. If the skin has been broken, you need to encourage free bleeding again, so a bit of squeezing around the outside of the injury. Wash the area with soap and running water, apply waterproof dressing, and report the injury and discuss it with GP or A&E, or get the parents to do it if it's a child that's been bitten that's in your care. If the child, I'm assuming it'll be a child, who's bitten another child, if there's blood in their mouth, get that rinsed out with lots and lots of water, get them to spit it out, and that can be quite challenging as well if it's a really young child. And again, report the date, the time, the name, discuss with the GP or get the parents to do so. Next slide, please. Splash exposures, again, wash the area, don't scrub it. If it's in the eyes, if you've managed to get blood into your eye, it's in your right eye, don't kind of lean this way so that when you're cleaning it out, it's all dribbling into your left eye. Just you make sure you're kind of washing it away. I don't know what I'm doing. Again, it's the same old here. Report date, time, names, type of injury, type of fluid that you've been exposed to, and again, with any concern, contact A&E or your GP. Next slide, please. Waste. It's generally assumed that people who are managing well in the community, who are living in the community, are relatively healthy and their waste is non-hazardous. If you've got any household waste that's kind of wet, so again, this can be like nappies in a childcare, in a childminder setting. You could just double bag that, so into the nappy sack and then into the waste, and that's generally fine. If there is a situation where somebody needs to have special waste collections, that is set up by their healthcare provider, and it's nothing for you to be worrying about. But if you have got any concerns about your waste, you can contact your local environmental health department or your health protection team, who will probably just tell you the number of the local environmental health department. But certainly don't be concerned about it. But if you do have any kind of specific queries, certainly either call environmental health or ourselves. Next slide, please. And always just remember that people don't come with a label. So, you might look at a 6-year-old kid and think, oh, absolutely fine, but you don't know what's wrong with them. So it's really important that we work safely all the time. And of course, if we're treating everybody in exactly the same way and we're using the same precautions for everybody, then it means that we're less likely to make mistakes and we're less likely then to be exposed to infection or expose others to organisms. But we must always have this routine practice at a high standard. Next slide, please. I'm going to rattle on outbreaks. I can see that Marie's kind of jumped in here because I know I'm rattling on a wee bit. Right, outbreaks. Let's go. Next slide. An outbreak is, the definition of an outbreak is where we've got 2 or more related cases of the same disease, or where we're seeing an increase of the expected number. And quite often where we're seeing this is in schools. A school knows, a childminder knows, a nursery knows what their normal absence rate is. If that's suddenly increased, that's a problem and we want to hear about it from you. So contact your local health protection team. Next slide, please. The health protection team will assess that outbreak, provide you with control measures. They'll do that verbally over the phone, and in some cases they'll provide you with written information. It may well be that we'll talk to environmental health, or we'll encourage you to do so. Care Inspectorate you would always be reporting outbreaks there anyway. And monitor the effectiveness of any control measures that we've talked to you about. Next slide, please. If it's diarrhea, and that would be diarrhea with or without vomiting. Next slide, please. So what is diarrhea? Next slide. Diarrhea, we're galloping now. 3 or more loose stools in a 24-hour period is generally the accepted norm, or a sudden alteration in the bowel pattern. If you've got somebody who moves their bowels 4 times a day anyway, and that's their normal, well, it doesn't matter that they've gone 4 times in a day. But if they're suddenly going to 8, that's a bit of a problem. So 3 or more, or a sudden alteration. Next slide, please. Lots of causes: bacteria, parasites and viruses. Loads of them can cause diarrhea and or vomiting, and some are more serious than others, and obviously things like E. coli 0157 we are quite concerned about, but there are other things, salmonellas, dysentery, those kind of things, and again we'd be concerned about that and we'd be speaking to the individuals. Next slide, please. The most common one that you're likely to come across, so that's going to cause an outbreak in your settings, though, is norovirus, and that's probably really common. We're certainly seeing a lot of it going around just now. Certainly will spread rapidly in closed environments like schools, nurseries, care homes, whatever. In schools, it's always the P3s I feel sorry for, because they're right in the middle of the assembly hall, so if anybody around them's vomiting, they're the ones that are going to get it. So yeah, really common. Next slide, please. It's fecal oral route, but also you can have, there's an airborne element to it. So if children, anyone, not just children, are vomiting, you have this kind of splash effect, and then these kind of small particles that'll fairly go a distance. And these particles can survive for days on surfaces if these surfaces are not cleaned, which is why we always recommend cleaning a 3-metre area around any spillage of, particularly of vomit. Next slide, please. Abdominal cramps, nausea, vomiting, diarrhea, but they'll have muscle aches, headaches, they'll just feel exhausted. And quite often this lasts anywhere between 12 and 60 hours. It's usually a short, sharp, feeling horrible, next day or the day after feeling fine again. However, there are some people that can have serious complications as a result of norovirus, but they would generally be older people. Next slide, please. Is this going to work? This is just an example of what it's like when somebody vomits and how far it spreads, but it's not real vomit, so don't worry. Okay. You see how far that's spreading. Okay, next slide, please. So that you can see from that how far that has spread. It's quite a considerable way. And when people are sick, they're not just sick and a little pile of vomit lands at your feet. You know, that it is this kind of massive spread. And so that, again, it just shows visibly there why it's so important that we clean that whole 3-metre area around. We need to break the chain of infection. That's what we said earlier. We need to keep doing that. We need to exclude symptomatic children and staff until they're 48 hours symptom-free. Staff, nurses, doctors, teachers, we're all really bad at this. We think we need to go in because we're going to drag ourselves in because everybody's so busy. It's much better one person is off this week than 5 people are off next week. So really make sure that people are not coming in. Be careful as well around the 11 o'clock when the Calpol starts to wear off as well, if you have been concerned about how a child's feeling. Remember, they don't actually have to have diarrhea and or vomiting for you to have concerns that they're not well enough to be there, because you have a duty of care to the other children as well. So it's really important that if you think a child is not well enough to be in your service, that they go home. You're not there to provide nursing care for them. So make sure you're promoting hand washing and keep your environment really clean, and that would include enhanced cleaning of surfaces like tap taps, the door handles, the flush handle, all the things that you're likely to touch before you get to the point of washing your hands, because these are all the things that can be contaminated. And just make sure that you've got adequate resources, you've got plenty liquid soap, you've got plenty hand towels, the wee hand towels or the paper towels, whatever you use in your service, and that you're reminding the parents and the children about the importance of hand washing and not coming in if they're not well. Next slide, please. In order to keep the environment clean, as we're just saying there, you move as much of the virus as you can, move as much as the dirt as you can. So it's got good basic cleaning followed by disinfection, and that would be using a chlorine releasing solution would be the best thing. There are some local authority areas we find with schools and school nurseries that they don't want to use chlorine releasing agents. They'll only use things like Oxyvir. And what we did locally in Grampian is worked with our local authorities to come up with a process for each local authority and what they did in terms of cleaning and disinfection. And certainly we could share that with our Grampian childcare providers. A real deep clean should be done after the outbreak is over. When there's an outbreak, during an outbreak, especially a GI outbreak, we'd also be asking the nursery or the childcare setting to take away messy play. We wouldn't want you making Play-Doh, for example. We wouldn't want you doing water play. We wouldn't want you using sand play, because these are all things that the children's hands all guddle together in. We wouldn't want them helping themselves to food. We would want them to be served their food portioned in order that they weren't handling food that was going to be handled by other children. What I will say, and what we have certainly seen locally, is that the nurseries and the childminders have learned a lot of lessons after COVID, and certainly lessons that we wished other areas of the health system had learned quite so well. So quite often when we get a call now from a nursery or a childcare setting and they think they've got an outbreak, they've already set in motion a lot of the precautions that we would ask them to do. So that's been a really positive thing from our point of view, and I think they've learned the lesson better than almost any other group, to be honest. You have learned the lesson better than any other group. Next slide, please. So that was all I was going to say, but I just wanted to touch on one thing while we're at the outbreaks. There's been a lot of chat. We get a lot of chat in Grampian from nurseries, childminders, whatever. They're worried about hand, foot and mouth disease, and we knew that there were some questions had come in around that. So whilst you might have an outbreak of hand, foot and mouth disease going on, the children who have got the symptoms, if they're well, they can be in, because once their symptoms appear, they're no longer infectious. They're infectious before their symptoms appear. So to stop people coming in when they're well, I mean, obviously if they're not well, they shouldn't be there, but if they're well, stopping them coming in, it's too late to do it. The transmission event has actually already happened. So keeping them out of the service is not going to do anything. It's not going to stop your outbreak. It's not going to minimise the risk of your outbreak. If anything, it's the children then that have not had it yet that are probably the ones that are more likely to be brewing it. But again, you can't exclude them because you don't know that they're going to be. Okay, Fiona, it looks like somebody's jumped in a question after on the basis of that, yeah.
Kim's got her hand raised to ask you a question. You're an absolute legend, Fiona. I don't know how you managed all that. Thank you very, very much. It was very, very informative. Kim, I don't know if we can unmute you and let you ask your own question. Can we do that, Jenny?
Unfortunately, the mics are disabled, Marie.
Oh, are they? Okay. So sorry about that, Kim. We've tried our very best to answer your questions as we've gone along. I'm ashamed to tell you that at the beginning I forgot to introduce Jackie Dennis, who is our Senior Improvement Advisor with a focus on IPC, and she's the organiser of this event tonight, and she's been doing all the hard work in the background to get everybody together to answer your questions and to give you as much information as we can. Jackie, my sincere apology.
Not at all.
We've kind of overrun quite quite a lot, and I'm wondering is there any specific questions or priority questions that we want to answer for people, or has everything been answered in the chat? How have we done?
I think it's been fastest finger first in the chat, to be honest. And Helen Corrigan, again, is another legend. I think the majority of questions have been answered. The hand, foot, mouth one was coming up quite a lot about the exclusion periods. The other one that keeps coming up is around hand hygiene, using like how do you wash an under fives, but again that was in the chat and it's been well and truly answered. The other one is around soiled linen, soiled clothing. We have nappy changing guidance, as everybody knows, and then that it talks about removing this, finding a storage place to store the soiled clothing. So again, that's been answered in the chat, and I can help to take that back to help inform the next iteration of the nappy changing guidance in relation to that, because some people on the call will know it's under review at the minute. One of the things that came up was around when, particularly for childminders, if you've got an animal at home, like a dog or whatever, is it okay to have dog food out? I know this will sound madness, even as I'm saying it, I'm thinking it's sounding mad. And also like for the children to eat while the dog food's on the floor. So I don't know if any our royalty, health protection royalty, is get any views on that, Helen?
Yeah, I've got views on that. Gonna know, because the dog, it depends on it doesn't really depend on anything. I would say no, there shouldn't be dog food or dog bowls around where children are, especially if they're not your own. Dogs carry all sorts of different pathogens that are zoonotic. That means that they can transfer their infections to humans. The dog may be completely well but not display symptoms, but the child can pick it up through exposure to the dog bowls or the water bowls and things. I think it really doesn't depend what you feed your dog, but things like raw dog food shouldn't be near humans anyway, because it's hootchin with E. coli and salmonella, and other pathogens, and kids will go and fiddle with dog food, especially if it's dry kibble. They'll love playing with it. It's a nice feeling in their hands, and we really don't want children playing with that or putting it in their mouth. So I would say that there shouldn't be dog bowls and things round about where children are being looked after. And I realise that that's maybe controversial in folk like Rover, but at the same time, Rover is a bit of a danger to the children, especially if, when they're out and their paws are coming in covered in things with the golf course and stuff. So it would be a no from Helen, I'm afraid.
Any other views? Anybody else there on the panel happy with that? Fine. Also, some of the questions is around double gloving. Should you wear 2 sets of gloves to change a nappy?
No, there's not really any need to wear 2 sets of gloves to change a nappy. I mean, if your gloves become really heavily soiled with feces or something when you've been in the process of changing the nappy, then you might need to have a think if you're using a cream or whatever. But there's not really any need to routinely wear double gloves.
Perfect.
Who's got the money for 2 sets of gloves, Jackie?
Yeah, it's that pops into my head. You're not going in to do an operation. Yeah. You're changing a baby's nappy. So yeah, you've really answered everything that's in there. One of the questions that came in out with was around outbreak management. If a child, if an outbreak of norovirus at a school, and then they go to a registered care service afterwards, and they don't have any cases, but the child attends, and then the service, one of the siblings in the service becomes unwell, is that reportable? Fiona?
I got distracted by one of the chats that's going on in there. Sorry, can you say that again? Sorry.
If you've got a child that's, like, say, get norovirus at school, there's been an outbreak at the school and they're attending, you've got a child in a registered service who's a sibling of that child, and they then become unwell, is that reportable? They're asking here is, do we need to report that? And I know from a care inspector point of view, yeah, they would, if it's definite, if it's defined as an outbreak, it has to cause an outbreak, if that makes sense.
Yeah, generally we'll get a call from services saying that they've got 2 or 3 children off or whatever, if it's a small service, or from a nursery or whatever, they've got quite a lot of. As I said, it's if you're absence rates suddenly seems to increase, and you know yourself if you're going to have, however, you know, like if you normally have 2 or 3 people off, it's not a problem, but suddenly you've got 10 off. So yes, if there's an outbreak ongoing, or you think you've got an outbreak, you should contact your health protection team, and part of the conversation that we'll have is around, yeah, you've got an outbreak, you need to let the care inspectorate know, and that's basically it. But you don't need to then let them know about every other single person
That's right.
afterwards that becomes unwell because you've got an outbreak, and we'll advise you when that outbreak's over as well.
Helen, do you want to come in?
Yeah, was your question round about if there's a child in the set-in who has a sibling who is symptomatic, can that
Yeah.
child come into the set-in? Right.
Yeah.
So yeah, as long as that child is well, it can come into the set-in. But the first sign of it looking well, it's out. But the other thing is some set-ins, we know that some set-ins have a policy, and this is entirely up to their own business model. If they have siblings who are off with like GI symptoms, they don't let that child come in, but that is not our advice. If the child is well and able to engage in the activities in the set-in, then it can come in.
Perfect. I think I'll wrap it up there because we're running a bit late, and I'm going to hand you back to Marie, who'll close the session for us. Oh, sorry, Fiona, you've got your hand up.
Yeah,
Sorry,
I just wanted
Marie.
to, there's been quite a few questions around fevers, and this is something that we get quite a lot of calls about as well. There isn't a specific, you need to stay off for 48 hours after having a fever if that's the only symptom that you've had. But generally, it's back to basic principles. Children shouldn't be coming in if they're not well. So if they've got a fever, they're not well, and they need to stay off until that fever has resolved and the child as well. And I said earlier, I think one of the things is around certainly knowing the kids that are in your care, but also maybe about knowing the parents that are in using your service as well. So if you've got a child that was not well and feverish the day before, and they're brand new, they're fine, they're back together today, the next day, but actually when you see them, they're kind of a bit hingy, they're not themselves, and then come 11 o'clock when the Calpol's worn off, they're hot again, then you need to get them off and be really clear with the parents that they've not to come back until they're completely well.
Excellent.
Thanks, that was really good. All that really remains, I don't want to keep people, I know it's been a long day for folk, and I want to just remind you that we'd like you to complete an evaluation form for us so that we can think about what we do next in terms of what you'd like to hear about. And also, if you could scan the QR code, that's the SSSC's QR code, that would be really helpful as well. Your responses are anonymous, and so we can't give you kind of individual answers, but you can always email us or get in touch with us. I'd like to again thank very, very much our expert panel, Fiona, Helen, Rona, Chioma, Jacqueline and Joanna, for coming along tonight and giving us their expertise and their advice. It's been really helpful. It feels as if it was jam-packed. There's certainly lots of stuff from what was said that I'll be putting into play. I can tell you I'll be putting the Lego in the dishwasher now. I never thought of that before. But I really want to thank you very much for coming along tonight, and we'll get the slides out to you. And I think we're sending out the questions and answers, are we, Jenny? Is there a frequently asked questions? Is there a plan to send them out separately?
Jackie and I can have a look at collating them.
Okay, just because I know just what Fiona said, there'll be things that have come up, a number of times, and it might be useful to people to have that. So thank you very much. Is there anything that I've forgotten to say, Jackie, Jenny? We appreciate that we're over time, and we thank you very much for staying on to hear us, and we look forward to speaking to you at the next event. Thank you. Bye-bye just now.